My mom was recently talking to her physician about some treatment options, and he sent her a couple of studies to read, which if you're not used to sort of reading a scientific study, it's really hard to do. So she sent them to me, and I was like, oh, this doctor might regret sending me, because I went through and kind of bulleted out kind of, well, this is what this study showed. And I think that's another important thing to think about, though, is when your physician says, well, a study shows this or this study shows that, to like you said, push back, ask questions, have them help you understand it.
And I just moved here about a year ago, actually. So how long have you been in Boston and with BU?
Yeah, it's funny because it'll be 20 years this fall. I came here to do my undergrad at BU, and I majored in math, and went on to work for a small consulting company in the Boston area, and then went over to the Brigham, around 10 years ago, to start my PhD. So I've been sort of kicking around the Boston area, around BU, around the Brigham, for almost 20 years.
Wow, I know.
Which seems impossible.
I work at the Brigham now, and I'm trying to find in my next steps ways to stay in Boston. So I think once you're here, not very many people want to leave. It's a fantastic.
There's so many opportunities and so much cool research, and it's at BU, it's at the Brigham, it's at Tufts, and I just feel like we're spoiled,
Absolutely. So, and tell me, we're really here to talk about osteoarthritis research and kind of bring the community, the osteoarthritis community, a consumable way to talk about research, right? We're trying to bring the scientists kind of to the people. That's the point of this. So talk to me about how you got into the OA space, and do you have any personal connection or just sort of happened through your work?
Yeah. I mean, I sort of fell into it a little bit. I was looking for a dissertation topic, and my mentor, Elena Lasana, kind of had this idea about trying to measure progression in osteoarthritis in the face of these cohort studies where a lot of people drop out of the study and so are kind of no longer being followed. And so how do we kind of accurately measure progression over these long periods of time, because OA is sort of a really long term, slowly progressing disease. How do we kind of accurately measure that progression when, people are dropping out, they're moving away, they're undergoing joint replacement and things like that. So that seemed like a really interesting topic to me. I've been interested in missing data since I took a class on it in graduate school. So that kind of came together with my statistical interest in this kind of missing data and longitudinal analysis, and then Elena's kind of research question. But it's funny, after I started working in kind of the OA field, my husband actually got diagnosed with hip osteoarthritis. So he had FAI, femoral acetabular impingement.
Yes, acetabular impingement.
And had to have surgery on both hips for that. And when they went in and did the surgery, found he had hardly any cartilage left in his hip joints. And one of the problems we talk about a lot with osteoarthritis and the treatments for osteoarthritis is that we have this sort of joint replacement surgery as kind of a final treatment, but we really don't like to do that until somebody has progressed quite a bit. And so if somebody is in sort of this stage of mild disease, relatively young, my husband was in his late 30s, there just wasn't a lot they could do for him. His surgeon basically said, you want to wait till you're in your 50s to get a hip replacement. So hang on till then, and there's just not a lot else we can do. And so there's been, I think, a renewed sort of research focus in this early OA, treatments for people with early OA, preventing progression of OA, because in this situation where somebody is relatively young, has mild disease, we sort of just tell them, there's not a lot we can do. We don't know how fast it's going to progress. Hopefully you can hold out till you're older to get a joint replacement, and good luck. Yeah. And it was, even though I sort of knew from my research life that was how patients were managed, it was still a little bit shocking to be sitting in a surgeon's office with him realizing there's nothing he can do for this joint pain, and seeing how it affects his daily life. And it's, not affecting daily activities at this point, but things like riding a bike or going for long hikes. And I think, geez, he's only in his 40s, we should be able to do this stuff. So that really hit home kind of this gap in our treatment strategies for osteoarthritis, that there's still a lot we don't have anything to tell people. And that's really tough.
Yeah. I mean, I've talked about this on previous vlog episodes as well, is that I am a PTOA patient. I've had multiple ACL tears from playing sports as a young kid, and I'm in the same boat. There's nothing for me.
Yeah.
I think, thinking about sort of this doom of like, okay, well, someday your husband's going to need total hips, which sounds crazy, right? Like they're going to replace his hip joints. It's wild to me. And I completely agree. I think, there's this need for not only a way to assess somebody's progression, but then how can we help these people, not progress as far as they are. So, so tell me, so you work in the area of really bioinformatics. And so tell me, give us for somebody like myself who was not a math major, really give us like kind of the breakdown. What does that mean? So you talked a lot about finding missing data and gaps in data. So tell us kind of about what that means to work really with the numbers of OA.
Yeah. I think a big push now, and we sort of touched on this, is trying to figure out who is going to progress. What does that trajectory look like? And I think that's, and this is true for a lot of diseases where people, come in and they say, oh, well, you have a 50% chance of developing this, or you have a 30% chance of developing that. And I think in OA, we don't really know what those numbers look like. And it's hard to tell, so you go into your doctor and you will have multiple ACL tears and they say, yeah, you're probably going to get OA. We don't know when, we don't know how severe it'll be. You might not, you might get lucky. And that's not really helpful for you. So one of the things with statistics, with this bioinformatics, is trying to say, based on everything we know about you now, based on your history of injury, based on other characteristics, based on, biomarkers we might measure, are there ways that we can kind of predict what's going to happen to you? And I think that helps in two ways. One would be, just sort of for you to think about what that trajectory looks like. Is it 10 years from now you might need a joint replacement? Is it 20? Is this something that you need to be planning for? And also how we treat patients. If you're somebody who is really unlikely to sort of get severe OA, then maybe you can take more of a hands-off approach. And if you're somebody who we're really worried is going to, develop OA really quickly, are there other things that we can do? And so I think it's trying to combine all of the information that we have and see if we can figure out what your sort of prognosis looks like.
Right. And I think, we, as patients, we hear, very little about the actual statistics that go into research, right? As doctors and are always like, well, the studies show and the research says this, but I think maybe to even break it down further, these statistics tell us whether or not, a treatment is effective or a likelihood of disease progression is supposed to happen. And so what you guys really do is take these big data sets and kind of distill down answers from them, right? Like based on all of this information, you're able to make some predictions. So how are you, what are you finding are the most important factors to making these decisions within your data?
Yeah, it sort of depends. When we think about these like risk factors, in terms of like what question we're trying to answer, and that's sort of I think statisticians love to say is, like what is the question? And there's a lot of people working on the kind of OA prevention side, right? To say if you're at risk of developing OA, are there things we can recommend that you do that might somehow mitigate some of that risk? So physical activity is a big one. Steve Messier at Wake Forest is doing a ton of work in sort of the OA prevention field. Can we do strength training? Is it physical activity? Is it flexibility? What are the things that we can do to try to sort of slow down the progression or maybe mitigate some of the risk of developing the disease? Weight loss is another big one. And so these so-called sort of modifiable risk factors are where you're really interested in like that risk factor itself. And if we change that, does it kind of change your prognosis?
Right.
On the other hand, there are things like, the imaging data. So you go in, you get an MRI of your knee, based on what we see in that image, what does that then mean for your prognosis? And there's nothing you can really do to change sort of like your bone shape, it's just like, it is what it is. But we can use those data to try to predict what's going to happen down the line. Similarly with history of injury, sorry to tell you, is a really big risk factor for developing or having progression of disease. And there's nothing you can do about your history of injury, right? You can't go back in time and not get injured. But it does give us some information about what your prognosis might look like. So we sort of tend to try to separate the models we're doing. Are we talking about kind of a model where we want to say, if you change this behavior or if you do this thing, maybe you can decrease your risk, versus kind of, here's what we know about your history, here's what your MRI tells us, here's what your sort of blood biomarkers tell us, and combining all of that together, what does your prognosis kind of look like? Not sure if that answers the question, but
it does. And I think it's important to understand that there are so many factors that go into the progression, speed of progression, severity of disease, and length, progression time, and that patients are multifaceted and variable. And, not everybody is going to have the same outcomes, because we're all so different. And so it's fascinating that there might be a way to kind of almost make it very personalized, where you can take all of these individual variables and factors for a person and kind of put it through your model and pop out and say, okay, this is the best prediction we have for you, which I think would be invaluable in a clinical sense. I think for patients to get a concrete sort of timeline, right? I think it's very hard to sit there and to hear, okay, you're going to be in pain at some point, and you're going to have at some point, and we don't really know when. And it's sort of like, okay, well, is that 2 months? Is that 5 years? Is that 10 years? Who knows? So I think this is such a fascinating way to look at the data, and really, it could be a very personalized experience for the patient, which is, I, as a patient myself, I think great.
Yeah, that idea of personalized medicine, like you're saying, of we have all of this information about you, and it's not just sort of your history, but again, if you go in and have imaging done, an X-ray or an MRI, you can plug all of that into an algorithm. This is where we get more talking about kind of the machine learning approaches. You dump all that data in and you get a prediction out. And people, they like that. So like, based on my personal history, my injury history, what my MRI looks like, my age, what does that mean for me? Instead of saying more generally, well, 50% of people are going to develop OA, or whatever the number is, really thinking about, your unique situation. And that's where some of these models that I'm starting to work with that can deal with these huge amounts of data really start to come in and be kind of necessary. Your traditional statistical model may only look at a handful of factors, but as you said, people are multifaceted, and there's so many things that are intertwined that you have to think about in terms of, predicting some of these risks, and how do we do that? And, you talk about this, so you throw everything into this black box and you get a prediction out at the end. And like, my job is to make sure that black box makes sense,
Well, and I think I was just going to bring up that point. You read my mind, was that I think for people who don't understand sometimes how, research, the inner workings of how we come up with conclusions, right? Because it's more than just, did we see this? There's statistical testing and making sure your methods are sound and stuff. But so I think sometimes people are like, okay, but how do I know that what this algorithm is telling me? So I think it's nice for patients to see a face behind that, right? Like there is humans who are double, triple checking, who are creating these models based on human factors. And it's not just robots who are like, in the world of basic science, and there a lot of times is not a tremendous amount of female PIs. And I think that's even less in the statistics and math world. So Jamie, how did you get into this space? Did you just love math from childhood? Or like, I think for me, statistics was like the bane of my existence.
It's so funny when you tell people you're a statistician, the number one most popular response is, oh my gosh, I had to take statistics in college. I hated it. That's what you do for a living? So that's a common response. And no, I've just always really loved math. I won the award for math in our 8th grade and, just continued from there. But it's an interesting point that you make about, women in STEM. And I was never encouraged to study math, to go into computer science, to do engineering, despite sort of winning the awards for math at every level. Despite one year in high school, I took 2 math classes because I really, really love math. And no guidance counselor, no teacher ever sort of encouraged that as a sort of viable career path for me. It wasn't until I got to college and met my undergraduate advisor who encouraged me. He said, if you're interested in statistics, like this is sort of a career path, in lots of different ways, outside of medical statistics, there's actuary science and business analytics and all of these things that are kind of open for you. But it wasn't until I was in college that anyone ever kind of brought that up as a choice,
Right. And, I think that it breaks my heart a little but I think we have all very similar stories about, I was a clinician that landed in research. And I think we've all sort of had these interesting trajectories. My gosh, because we're not funneled into like a mainstream sort of career path. I think like some of our, male counterparts might be. And so, I know that like, especially in bioinformatics and statisticians and engineering, and it's like, I think you sometimes have to fight a little bit harder as a woman for, to be successful in these fields because it's seen as a very male dominated space. And so and I think hopefully where OA is going, the OA world too, is into a more diverse and representative of the actual communities we serve.
Right.
I think it's so important for patients to see doctors and researchers and statisticians and scientists that look like them. Representation is so important. And so I love that your 8th grade math award.
And Mrs. Haynes, I'll never forget.
Well, and I mean, looking back, it's like that was sort of this pinnacle moment for you. And so what is the most, I think, exciting part of working with these big data sets? Is it finding that like needle in a haystack type, or is it really being able to like what kind of makes you so excited about the data that you're working with?
Yeah, I just think that the possibilities, we have so much data, there are all of these different algorithms, and so there's got I guess the needle in the haystack, there's got to be something in there. And you want to be careful not to sort of go fishing, but at the same time doing some exploratory work that says, we have all of this information. How can we best utilize it? And I think there are so many different statistical techniques. Now all of this machine learning is becoming so popular. So there are so many different ways to look at the data. And as a statistician, the job is to sort of bridge that gap between kind of the clinical question and the bioinformatics or the data, and ask, kind of what are the relevant questions and how do we answer them with the data? And, we talked a little bit before about, you just sort of stick everything into this black box and you get a prediction out. And it's a little more complicated than that. Yes. But part of the complication is, trying to work with clinicians, trying to work with doctors, people who are really on the ground working with patients, and say, well, what are the questions that patients want answers to? Right. It's not me sitting by myself with all of my data trying to answer questions. It's really thinking about what are the relevant questions for patients in this OA community. What do they want to know? And how can we use this data to help them? And kind of backing up from there, instead of, here's my data set with thousands of variables, I'm going to throw everything into this AI algorithm and get something out on the other end. I mean, you can do that, but that's not always so helpful. So it's trying to bridge that gap between, what are those really important clinical questions? How can we help patients? And how can we figure out how to do that from these huge data sets?
Yeah. No, and I mean, I think it's so, I've always, my previous mentor for my PhD, she goes, if I can give you one great piece of advice, make friends with a statistician. She said, because it's true. I mean, sometimes we, as a basic scientist, I live in the land of, I'm going to collect as much data from either my patients or my animal models, whatever it is I'm working on, as I can. And a lot of times it's all of a sudden you have all of this information and I'm like, I don't know how to do anything with any of this. And so it's, it's this marriage of clinicians and bioinformatics. And really, I think patient care is becoming more than just a doctor and a patient. It's
right. Yeah.
So much of a team approach of scientists, doctors, patients, all of us working together to try and find, the best outcome for these people. So, I think it's exciting to kind of see the face behind all the numbers, because before I got into research, I was like, who's doing these studies? Like my dog would be like, the studies show, and I'm like, who, right. What, where, when? Like I had all these questions.
It's interesting. There was just an editorial in the Boston Globe over the weekend about like artificial intelligence and these algorithms, and it was making the point you made earlier about it's not just some machine. There are the people behind the curtain who are making these decisions, but at the same time, it's important to recognize that it's these algorithms that maybe get spit out using the data from your medical chart. A person was behind developing them, which is, I think it's good. It's not just a machine, but at the same time, people are, we make mistakes too. And so really trying to think about how do we come up with these sort of, how do we work with data in such a way that, again, we can answer those important clinical questions. We can kind of understand the uncertainty around our predictions. The studies show that 15% of people with your history are going to develop OA. And well, is it really 15%? How big was this study? And so trying to really think about how we use those results in the real world. And I think that, again, that's something where the physician, the patient, the research team really all kind of have to work together, because those aren't things that are necessarily kind of intuitive,
Right. Absolutely. And I think it's so important too, to, understand that the algorithms and the machine learning is a tool to be used, right? That this is not the end all be all, but
that's such a great way to describe it.
It's a tool within our arsenal to help make better patient predictions. And I think that's the way to think about it. I think sometimes, I know, especially, my parents are a bit older and they get kind of not nervous, but a little like, okay, like, sure, but I don't want a computer to decide my clinical care, right? And so,
right, yeah, who would?
Right, we have to reiterate that the computer is a tool to help us. I mean, if you had to go through this kinds of data by hand, I mean, you would never get anything done. You'd just be drowning in data all day. So, it really allows us to be more personalized because we can use these tools. So, I mean, this is so, I love chatting with you about this because it's so far out of my wheelhouse. And I think sometimes people are like, oh, well, you got your doctorate, like, and I'm like, no, I got my doctorate in an area about this big. Like, that's my expertise where, so I think it's so great to get to talk to people on all sides of the OA puzzle. We're all trying to put these pieces together to somehow, treat these patients.
So fun about the research community that I think it's hard to explain to people who are outside of it, but to any patients who are watching, just that we all work together and are all learning from each other all the time. Like you said, we all have these sort of little areas of expertise, and like we're real experts in this one little area. And so it's trying to match up, what you're doing, what I'm doing, what somebody else is doing, and trying to do that with somebody who's working with patients so that, we can kind of put all of our heads together and come up with something that's going to ultimately help people. That's what we're all here for, why we're all in research, is to try to help people. And you kind of have to put your ego at the door and say, here's what I can contribute. You're going to tell me something about your rat model that I'm not going to understand any of it. And I'm going to have to tell you to slow down and, explain it to me like I'm a child, because I don't know any of these things you're talking about. And really kind of just figure out ways to work together. And I think that's what's so great about research, is this collaborative aspect of everybody taking their little areas of expertise and coming together to answer these important clinical questions.
Absolutely. And I love that about, I think, our generation of scientists and some of the younger generations of scientists who are kind of coming up in their careers now. And, we, I think, know the importance of collaboration. And I mean, I don't know a single one of my colleagues that's going it on their own. Every single colleague, a person I know, friends, are all working together in a team of collaborative research. And I think that that's in every field, not just OA, but especially in the OA field, because we know that OA is so incredibly complicated.
Right. Yeah.
You have to work together. So, I mean, that's something for me that I just love, how collaborative everybody is, and this kind of new wave of researchers who are truly, making it happen with each other. So it's fantastic. Yeah.
And just, for people to know that, again, like we joke about black box algorithms and stuff, but it's not just even one person behind the curtain, it's a whole team. And sometimes we disagree with each other, and people have different opinions of how to interpret the data. And so things go through sort of lots of cycles of thinking about things and debating things. So, when your doctor tells you, well, this study shows this, it wasn't that one person sat down and analyzed some data and this is what came out of it. It's a whole team of people were probably arguing and debating and passing things back and forth and thinking about it, to come up with this result. And I think that's an important thing to know about research, is that, we work together, and I think challenge each other in a way to really make sure that we can stand behind the stuff that we put out.
Yeah, I will never forget. I think one of the, my undergrad was a very small Division III college, great for the program that I was in, but not a big research, not a research institution. And so I wasn't really exposed to research until I went to the University of Kentucky for my master's. And I'll never forget, we were in lab meeting and the two PIs were they were having a spirited debate about the work. And I remember sitting there, I was like, and I, at the end, I looked at the postdoc and another PI, I said, oh my God, they got into a fight. Like and she was like, no, like this is what is supposed to happen. That wasn't a fight. This was, debating science and debating research. And that's what's supposed to go on. You're supposed to, hold everything accountable, question everything. And I think that's a great message to send to our patients as well, is, you should be questioning everything. Asked to look at your studies, at your x-rays and MRIs, and asked to, talk to your doctor and ask questions. And because that's really how you have the most informed care. And I think, especially, it must be so nice for your husband to have someone who's sort of on the inside, because you're there, you're like, wait a second.
Yeah.
I would like more information about that. Thank you.
It did. My mom was recently talking to her physician about some treatment options, and he sent her a couple of studies to read, which, if you're not used to sort of reading a scientific study, it's really hard to do. So she sent them to me, and I was like, oh, this doctor might regret sending me, because I went through and kind of bulleted out this is what the study showed. And I think that's another important thing to think about, though, is, when your physician says, well, a study shows this or this study shows that, to like you said, push back, ask questions, have them help you understand it. These scientific articles, we're so well versed because we read them every day, but it's hard to pick apart if you're not used to that kind of writing. And that's what's so great about this type of interview that you're doing, is to try to break things down so that kind of the average person who isn't a scientist can kind of understand some of the research. And I think that's an important thing. Somebody sending you an article from the New England Journal of Medicine about some treatment strategy, that might not help the average person. We need to kind of distill it down a little bit. And so asking those questions, having somebody walk you through what does that study really show? And there's been a really big push kind of in the scientific community to do these more sort of layperson summaries of the work. It's not enough to just write your scientific article. You need to summarize it in a way that the general community can kind of digest it. And I think that's something we need to do a better job at, so that when your doctor sends you a study and says, here's a study looking at physical activity and osteoarthritis progression, this is why you should start walking. We can have a summary of that really breaks it down and says, for the non-scientist, here's what the article is really saying. Here's the take-home message. And I think that's something that the field is moving toward more, as people kind of say, this research should be accessible to everyone, and we need to do a better job of making things more accessible.
Right. I couldn't agree more. And that's what I love about this vlog, is that it is for everybody. And we as an OA community are nothing without our patients. We have to be able to reach them. And,
right.
I think especially important for people like yourself in the bioinformatics world, because you have this unique opportunity to, help patients understand what data actually means. I could say all day long, well, my treatment paradigm seemed to work. And, but you get to come in and say, okay, but let's look at how they actually analyze that data, because that is what tells us whether or not something was effective. And so, you guys are so perfectly poised to be able to do that. And I love that the whole kind of community, but especially statistics and bioinformatics, is becoming more accessible to those people, because I think that's some of the last frontiers of breaking down these walls to reach patients, which, is so incredibly important.
Yeah. And again, I mean, that's, at the end of the day, that's why we're all here. And I think making sure that we can kind of bridge that last gap and not just say, oh, I came up with this cool prediction model, but okay, well, how is this going to work in practice? And I think in the last 5 or 10 years, the field has really moved that way, and saying, it's not enough to just do a cool analysis for the sake of doing a cool analysis. Really, what does this mean for patients? What does this mean clinically? And that's why I love, the field that I'm in, is that's what we're doing, is really trying to bridge that gap.
Yeah. Incredible. Well, Jamie, thank you so much
Thanks so much for inviting me.